COPD Exacerbation, Diagnosis, Pathophysiology, and Emergency Management, Part 1. Welcome to Medical Sciences Unfolded. Today, we're breaking down COPD exacerbation, one of the most common reasons for hospital admission worldwide, and a high-yield topic for every level of medical training. COPD, chronic obstructive pulmonary disease, is a progressive, largely irreversible airflow obstruction caused by emphysema and chronic bronchitis. A COPD exacerbation is defined as an acute worsening of respiratory symptoms beyond normal day-to-day variation that requires a change in therapy. The classic triad is increased dyspnea, increased sputum production, and increased sputum purulence. Exacerbations are classified by severity: mild, treated at home with increased bronchodilators; moderate, requiring antibiotic and/or steroid therapy; severe, hospitalization needed; and very severe, requiring ICU admission and mechanical ventilation. What triggers an exacerbation? Infection is the most common cause, accounting for 70 to 80% of cases. Bacterial infections, particularly Haemophilus influenza, Moraxella catarrhus, and Streptococcus pneumonia, are the classic culprits. Viral infections, especially rhinovirus and influenza, trigger up to 30% of exacerbations. Non-infectious triggers include air pollution, pulmonary embolism, heart failure, and pneumothorax. Always consider these in patients who aren't responding to standard therapy. The pathophysiology. In a COPD exacerbation, airway inflammation worsens dramatically. Neutrophils flood the airways, releasing proteases and reactive oxygen species. Mucus hypersecretion increases, mucociliary clearance is impaired, and dynamic airway collapse worsens. The result is air trapping, dynamic hyperinflation, and increased work of breathing. As the respiratory muscles fatigue, hypercapnia develops, rising CO2, which is the hallmark of respiratory failure in COPD. Assessment starts with oxygen saturation. Target SpO2 of 88 to 92% in COPD. Why not 100%? High-flow oxygen in COPD eliminates hypoxic drive and can worsen hypercapnia, the Haldane effect. Use controlled low-flow oxygen via Venturi mask at 24 to 28% FiO2. Arterial blood gas is essential. Type 2 respiratory failure, hypoxia with hypercapnia, shows low PO2, high CO2, elevated bicarbonate from chronic compensation, and a pH that tells you if this is acute or chronic. Acute hypercapnia drops pH below 7.35. A pH below 7.25 signals impending respiratory failure and warrants non-invasive ventilation immediately. The chest X-ray should be obtained to rule out pneumonia, pneumothorax, and pulmonary edema. All can mimic or trigger exacerbations. ECG rules out right heart strain and PE. BNP helps differentiate heart failure from COPD. Part 2. Treatment protocol, ventilation, and discharge planning. Now let's cover the treatment protocol for COPD exacerbation. This is the high-yield clinical management you need to know. First-line treatment starts with bronchodilators. Short-acting beta-2 agonists, salbutamol, also known as albuterol, and short-acting anticholinergics, ipratropium bromide, are given via nebulizer or metered-dose inhaler. Combining both provides synergistic bronchodilation and is superior to either alone. Give back-to-back treatments every 20 minutes in severe exacerbations, then every 1 to 4 hours as needed. Second, systemic corticosteroids. Oral or IV prednisone 40 mg daily for 5 days reduces treatment failure, speeds recovery, and decreases length of stay. The landmark REDUCE trial showed 5 days is equivalent to 14 days. Shorter courses are preferred to reduce side effects. Third, antibiotics. Give antibiotics when there is increased purulent sputum, increased dyspnea plus purulence, or severe exacerbation requiring mechanical ventilation. First-line choices include azithromycin, doxycycline, or amoxicillin clavulanate for outpatients. In hospitalized patients, a respiratory fluoroquinolone, levofloxacin or moxifloxacin, or amoxicillin clavulanate covers the classic pathogens. Duration is typically 5 to 7 days. Non-invasive positive pressure ventilation, BiPAP or CPAP, is a game-changer in COPD exacerbation. BiPAP provides 2 pressure levels. IPAP during inhalation reduces work of breathing, and EPAP during exhalation splints open airways and reduces autopeep. The evidence is strong. BiPAP reduces intubation rates by 50%, reduces mortality, and shortens ICU stay. Indications include pH below 7.35 with hypercapnia, moderate to severe dyspnea with accessory muscle use, or respiratory rate above 25. Contraindications: altered mental status, hemodynamic instability, inability to protect airway, or copious secretions. When does a COPD patient need intubation? When BiPAP fails, pH below 7.25 and worsening despite NIV, cardiac or respiratory arrest, inability to protect airway, or profound hypoxemia. Use volume-controlled ventilation with low tidal volumes of 6 to 8 milliliters per kilogram, low respiratory rates, and prolonged expiration time to allow full exhalation and prevent autopeep. Discharge planning is crucial. Patients should be discharged on optimized inhaler therapy, typically LABA plus LAMA combination, and reassessed for inhaler technique. Pulmonary rehabilitation reduces readmission rates by 30%. Smoking cessation is the single most effective intervention in COPD. Vaccinations, influenza annually, and pneumococcal prevent future exacerbations. Long-term oxygen therapy is indicated when resting SpO2 is 88% or below, or PO2 below 55 mm mercury. It's the only pharmacologic intervention proven to reduce mortality in COPD. To summarize, COPD exacerbation is triggered by infection in most cases. Assess with ABG, chest X-ray, and ECG. Treatment is controlled oxygen targeting 88 to 92%, nebulized bronchodilators, 5 days of steroids, antibiotics for purulent exacerbations, and BiPAP for pH below 7.35. Know your BiPAP indications and when to intubate. Discharge with optimal inhaler therapy and pulmonary rehab referral. Thank you for watching Medical Sciences Unfolded. Subscribe for daily medical education.